It's all in your head. You don't look sick. Your tests are normal. It's probably anxiety. There's nothing wrong with you. Have you heard these words from physicians, family, and friends? If you're someone who has been struggling and swirling through the revolving door of healthcare to find answers about your health, or if you know someone who is going through this experience, then this podcast is for you. Welcome to the Desperate for a Diagnosis podcast with Laura Nozicka.
Hello and welcome to the Desperate for a Diagnosis podcast. I am your host, Laura Nozicka. I'm here today with Laura Badmaev. Am I pronouncing that correctly?
Badmaev.
Badmaev. Thanks, Laura. Thank you. I'd like to tell you a little bit about her, and she is so involved and entrenched in helping parents in particular. She is a parent. She has done some amazing things around this very, very rare genetic disorder has been discovered in the context of children. And it's so rare that there's very few physicians that even treat it or have a specialty in it. And we're going to learn a lot from Laura today. But let me tell you a little bit about Laura. She is the founder and chair of the ASXL Rare Research Endowment Foundation, and mother to Alex, who has, I'm gonna botch this too, Laura, Bohring-Opitz Syndrome, which is the ASXL genetic mutation. She is dedicated to advancing evidence-based research and enhancing care for families affected by this disorder or these genetic mutations. Originally from the New York metropolitan area, Laura now resides in southern Maine with her husband, Michael, and their children, Alex, Abigail, and Natalia. She has a BS in Operations Research and Industrial Engineering from Cornell University and a Master's in Systems Engineering, along with a graduate certificate in Engineering Management from Stevens Institute of Technology. Laura also holds a certificate in Leadership Excellence from Harvard and certifications in Scaled Agile Framework and Six Sigma. She has an extensive background, having worked for the Department of Defense as an integrated logistics support manager and systems engineer advisor, and later transitioning to American Express, where she has held consultative roles for over a decade. Laura's work has been recognized with honors, such as the 2018 American Express Top 10 Global Parent of the Year Award, 2019 Mother of the Year for Working Mother Media, and the 2021 Chairman's Award. And outside of that, I don't know where she gets the time. She is still passionate about travel, cross-cultural relationships, and supporting the ASXL disorder community through her foundation, which we're going to hear all about. Laura, thank you so much for being with me today.
Thank you so much for having me. I'm excited to be here.
Yeah, good. I should say that you were introduced to me through Dr. Lauren Strauss, who is the pediatric neurologist who I had on the show not too long ago, and we talked about all kinds of rare pediatric neurological conditions like Alice in Wonderland syndrome and a few other things related to possibly being manifestations of migraine and things I had never heard about in my market research travels. But I think our topic of conversation wins from the standpoint of rare orphan conditions and have never heard of this genetic mutation. And I'm excited to learn from you and all the work that you've done. So let's just jump right in. The ASXL mutation, I saw on your website that there's mutations 1, 2, and 3. So help us understand, what is this mutation? How are these different expressions different from each other? And what are some of the symptoms of this condition?
Absolutely. So these are random mutations that sometimes happen around the time of conception in this ASXL gene family. In my experience and a number of other families, it was a completely uneventful pregnancy. So there was no indication at all at any point in time that anything was wrong or coming up on any tests. It wasn't until after our son was born, 40 weeks and 2 days, that people knew, like the medical professionals at the NICU knew something was different from a combination of features. So in our case, Alex had these low set rotated ears. He had a small mouth. He had long fingers and he had failure to thrive. It was really difficult for him to feed. And so they ran, all the traditional, like a whole bunch of different tests trying to figure out what was going on with him. They did a karyotype and a microarray, which are some of the standard genetic tests, and there were no conclusions. So they discharged us from the NICU, and it was actually
Where was he at preemie then? Because he was in the NICU.
no,
What was going
he
on?
was 40 weeks and 2 days. But it was that he had aspirated meconium. And so they had intubated him, and so he was rushed to the NICU for that. He was like 5 pounds, 9 ounces, so on the smaller side, but not tiny, and he was full term. So, we were there mainly for a few weeks because he wasn't able to feed, and they were trying to decide what to do. And there was a strong push initially towards breastfeeding, and then eventually they were having to do like supplement with formula, and it could take him sometimes up to an hour and a half just to have 2 ounces through like a mini Haberman bottle, which they give for children who have cleft palate. It's really slow drip. And so that was sort of, we were sort of rushed into this whirlwind of like, where are we and what's happening? It was like I tried to do everything perfect during my whole pregnancy and read all the books and ate all the vegetables and did all the prenatal pool and yoga classes, and what's happening, right? And it was Dr. Strauss that you mentioned who connected me with a neurologist at Boston Children's, who then also connected us to a geneticist who um, has followed Alex for like, his last 13 years of his life and become one of our medical advisors and an expert in this space. But yeah, I mean, it took us several years before whole exome sequencing was available. So we spent the first few years of his life just meeting with all these different specialists, trying to eliminate different diagnoses of what it wasn't, and meanwhile trying to deal with all the symptoms. And then, whole exome sequencing, we started to get some preliminary data in 2014, and then within a year, it was confirmed, and he was the first case diagnosed. But going back to your broader question of the ASXL3, so there's ASXL1 is Bohring-Opitz Syndrome, ASXL2 is Shashi-Pena Syndrome, ASXL3 is called Bainbridge-Roper Syndrome. And there's some commonality in terms of challenges with like severe intellectual disability, cognition, and communication, with gastrointestinal issues, with behavioral issues. But there's a very significant spectrum. And then each syndrome also has their own challenges. So like, for ASXL3, they, have some challenges with like teeth, or their behaviors are more severe. ASXL2, some of the children have issues with like heart, and there's more similarities with autism. ASXL1 has a lot of mobility issues and more respiratory issues. So there's some that, like I said, are common and some that are different. So it's a pretty large spectrum.
Mm-hmm. And since the genetic testing wasn't available at the time that you were trying to eliminate diagnoses and having your own desperate for diagnosis moments, of course, several. What was the catalyst to this specific genetic panel being developed? Was this in research all along, or was it something that you jump started, or how was this research being developed to actually create this panel?
So, whole exome sequencing, I think at the time that Alex was chosen, he was one of the pioneering samples. And it's a very robust, complicated test that at that time also required a clinical overlay. And so like it was, I think they tried doing other types of, it was more of like a process of elimination, I would say, right? So like we met with someone, an endocrinologist, like, okay, Alex doesn't have cystic fibrosis. Like we would meet with all these different specialists and they would run different types of tests and different types of panels and there just wasn't anything. But like I would say that it was really our genetic, we were very fortunate to have a geneticist who was determined to find a diagnosis and like connected to the broader community, right? And there was, I think, earlier cases that were diagnosed clinically in the Netherlands, but not so much here. And so this was like because it was such a molecular level change, like no one was able to even test to be able to find such a diagnosis because the testing that we had available couldn't pinpoint what was happening. They just knew like more so that there was overlap with many other similar conditions where there's like global developmental delays, you have trouble feeding, like, you have other similar symptoms.
There's so much on the list that
Right.
there could be the differentials very long, I would think.
Yes. I mean, I think there's new things with time, like whole exome sequencing is becoming much more prevalent. It's a like small fraction of the cost. It's much more readily available. I know Columbia Presbyterian is actually doing this for every single baby now who comes through. So I do think, and we've learned that, probably in the next decade, maybe every pregnancy will have this test and people will learn all types of things that they never knew about their children, whereas like this just wasn't available. When we were coming through the system because of the it didn't exist and the costs also over time was really high early on. But like I've met a family who, their child, they eventually gave up at age 7 and then 20 years later, their geneticist was at a conference where they heard about Bohring-Opitz and they said, let's pull the file and test. And so I think it's also a matter of like, do the providers know? Is there awareness? And so we definitely have a big push about spreading more awareness. We also participate in the Face to Gene project where they take craniofacial 3D imaging and providers can take a picture of a child and match it to this database and they can get a diagnosis.
Oh, wow.
Is sometimes it's like some of our children have like these heart-shaped birthmarks or certain facial features and where they oriented. And when you run a traditional like database query with the symptoms, you don't necessarily get to where you need to go. So, and another way that we're doing diagnostics is with methylation patterns. So, Sick Kids Toronto has been able to do this for ASXL1, and they're expanding to the other disorders. And you can see similarities too between our disorders and also other ones in the broader chromatinopathy family we're part of. But in addition, it helps, like sometimes people have variants of unknown significance in these genes. And so you can tell, like, someone could have a mutation on ASXL1, but that doesn't mean they have Bohring-Opitz. So, like, there are adults who have mutations in these genes who have all kinds of cancers because it also depends when the mutation happened and where it happened, right? So,
Because
Right.
I think I read that it's genetic mutation with regard to the effect of the proteins, and so many cancers are protein triggered, I guess I'll say. Yeah, so it's amazing how it's all connected, and we just things we just don't know about our DNA that could be affecting us, and it seems like things we just live with or deal with are kind of benign, but we just don't, because those just aren't tests that, unless you're showing some type of presentation or an issue symptoms, then those are just things we don't know about unless you're doing 23andMe or any of those other things.
Absolutely. And I think for when you live in this ultra rare disease space, the diagnostic journey continues, right? Because there's no limit to what we don't know. So like last year, our son was diagnosed with chronic kidney disease, but there's nothing in medical literature about it. So we've been able to bring that back to our providers. And now there's like a bladder and kidney registry survey for families to start collecting that data. So hopefully we can learn more and put it out there so people know what they need to do. Or, when Alex was first diagnosed, there was no one else in New England, and I connected with another family on social media, and their daughter was having her kidney removed because she had Wilms tumor, and the tumor had spread all over. And, at the time, no one knew anything. So I connected our geneticist to hers. And then they ultimately published an article in the American Journal of Medical Genetics. And that's where you see like the power of research and finding out, just, I mean, like getting the broader diagnosis is one aspect, but then it's like, what is the ripple effect of implications of things that you need to monitor and look for and other subdiagnoses along the way?
Yeah. And Laura, you mentioned Boston. Is Boston Children's heading up or spearheading the research, or are there other universities who are working research for
So
mutation?
absolutely. So, the ASXL registry has now become a natural history study. The primary site is at UCLA. The other sites are Duke, Cincinnati Children's, and Boston Children's. And we've had some transitions that we're working through with some of the other sites of providers. But the other main site that recently joined is Kennedy Krieger Institute, which is an affiliate of Johns Hopkins. It focuses on neurodevelopmental disorders, and they're running an ALP study, which it's a behavioral phenotyping study looking at like the cognition and the behaviors and being able to quantify and assess all different aspects of delays and pairing that as like a subset of data to the broader natural history study, which looks like long term, collecting all different types of data. And there's an associated biobank with like skin biopsies and buccal swabs and blood samples that are then made available to the researchers. So it becomes an incentive for people to want to study these syndromes. Um, but yeah, that's I would say so our primary, I mean, we're looking to, expand also to antibodies and other ways that we can help to set the table and bring more people into the mix. Like we've grown our professional network very significantly from like there was only maybe 10 people looking at this when we started, and now it's like close to 90 through a lot of like personal outreach. We do annual research symposiums. We do quarterly virtual roundtables with professionals to share ideas and connect labs and pique that interest. And we also connect that professional community to the families and share data and information. So that makes it also easier for them to do the work and for people to study what we're doing and put more information out there. So hopefully more people do get diagnosed.
Yeah. How is the research being funded currently? Is that all through your foundation, which we'll talk more about, but how's that working?
Yeah, so it's really challenging in the rare disease space, right? Because there aren't a lot of funding sources and opportunities, and so scale and partnership and how you need to really be strategic in this space. There's some aspects that have been in kind or supported, like from universities and hospitals. We've funded over the years like over $825,000 of grants. We've also received various grants like the PCORI's, I think the Patient Centered Outcomes Research Institute, looking at defining and prioritizing research objectives and outcome measures. Um, but, I mean, it's a big challenge, and then also, like, where we can, we define ourselves as, like, neurodevelopmental disorders and, like, some of our children also have epilepsy, chromatinopathy, like, where you can connect to the broader space and sort of be included in some of their studies as, like, an add-on because you have some elements that are similar. We look to try to leverage those opportunities as well. But
Mhm.
it's a challenge, right? I mean, it's being ultra rare, there's not as many people, to help,
And,
and that's one of the reasons we have all 3 disorders too.
and grant writing alone is an art, I understand.
It's a lot, yes, it's very challenging, it's time consuming, it's a lot of work, and we, some of our researchers also, apply for various NIH grants, and we've had people from, like NIH and FDA and different federal organizations come to talk to our professionals about like different grants that they could apply for. And again, sometimes it's us as part of a broader grant with other diseases so that, it makes it easier from like a scale perspective.
Yeah. Are you working direct with industry, meaning pharma at this point?
Not a lot. There's some level of there, part of the challenge is that we don't fully understand the mechanisms, and there may be like many of them. These are like some of the most extremely complicated disorders that exist, right? And so, because of that, it makes it really hard to determine a development pathway to treatments. Like, we've had assessments to understand the lay of the land and what are all the things that are required to get to that point, so that like, you're probably familiar with like things like biomarkers, right? It's almost an outcome measures. So, how do you have a baseline starting point by which, if you were to implement a drug, you can show progress? So, there's steps we're taking to improve preclinical trial readiness. And we're having conversations with people in the pharma world to advise us so that we can be prepared and do this the right way. It is challenging also because of the large spectrum and needs and various priorities and the family's desire to have more support now. So that's also something to manage, and as well as looking at other organizations and what they're doing in this space. So things like drug repurposing studies and what are other avenues that we can pursue.
So no treatments on the horizon at this point.
No, no.
Yeah. So most
Attorney. Oh, yeah.
for sure it is. And like I mentioned to you, I do market research for pharmaceutical companies, and it is a long haul. In fact, I had worked on a clinical trial patient recruitment project some, I don't know, 9 years ago, and it wasn't up until I think last year that the drug that I was working on actually got approved. So it is a long journey. And so I think I had read on your website that now it's just a matter of symptom management for these children in terms of, yeah, they're either epileptic or some of the heart problems you mentioned. And
Right.
what's the challenge behind that for the families?
It's really hard because also our children present differently than other children do, and they require different types and dosage. So, for example, like, your child may have some kind of infection, but they're not going to have a fever. And so when you go, especially to like an emergency department or someone that doesn't really know your child, and they're looking for the checklist of these are all the symptoms for this problem, and your child doesn't have that. And it's like, well, and another really big challenge is our children are completely nonverbal. They have many of them have no words at all, and they're also having severe intellectual disability, right? So my son is basically like 9 to 30 months, like a toddler. And so imagine, so then what happens is they're in a lot of pain, they can't communicate, then they start hurting themselves, like biting, kicking, poking their eyes. Like, some kids have displaced their retinas and caused blindness, right?
Oh my gosh. Oh,
It can be
that's
very,
with like they don't know how to handle or process pain. I mean, this is how they're doing it.
and there's so many different things. Like, I remember at one point, my son, it was like half his femur was out of the socket, and he was having severe, like, high grade urinary reflux, and he was on like 14 antibiotics in a year. And, he's got all this metal on his body, and maybe he also has headaches. And I mean, there's so many different things that are going on. You're constipated, like, you can't sleep, like, he's having all these different issues, right? And how do you even come to like, what is like, which symptom are we resolving right now? Like, what's the priority and how do we address this? And then,
What specialists do you see today, right?
yeah, you need a really good complex care doctor or palliative care team, which not everybody has that. And then the dosage, like, sometimes our kids respond better to like a fraction dose, right? Sometimes regular dose has like a paradoxical effect. So it's a lot more complicated. So we launched this year an ASXL care directory that's family sourced. So we asked families for their recommended healthcare providers, and that has like three goals. The first is just, developing this list of providers. The second and medium term is like, okay, starting to build some of that ASXL expertise by sending these families to the same providers. And third is like long term, ultimately having people who have this ASXL expertise that they can develop those standards of care, which we don't have right now. Right now, a lot of it is family sharing information, social media, meeting at conferences, trying to make connections of like what worked for your child or like what's learning about this other new symptom that might happen. And then some of that we bring back, like a few years ago, there was a girl who had liver cancer and like we brought that back. And now there's, screening guidelines that, our medical advisors have published for everyone so they know to get these abdominal screenings, not just to look for the kidney cancer, but also liver cancer. And then there could be incidental findings of gallstones and other things, right? So it's very much kind of, we're working through all of this together and trying to formalize it over time.
Hmm. Laura, what's the N of children who have been diagnosed with any of these three mutations?
So, we say it's 500 plus, but we know it's growing significantly, which is why we're planning to do a census in the next couple quarters to get a better estimate with whole exome sequencing becoming so much more readily available. A lot more families are joining these Facebook groups. We see more families reaching out to us. We were starting to do more newly diagnosed calls. So we believe it will be more with time, but it's very low in the big scheme of other diagnoses at this point.
Well, yep. So how do you guide a family that maybe they don't I mean, I can't even imagine you have a child who has all these symptoms, all these things are happening to them, and now you're in this position where I'm guessing you're starting with the pediatrician, and the pediatrician is again trying to maybe eliminate certain conditions, diseases, and it's maybe basic testing. Okay, well, next step is depending on what symptoms the child is exhibiting. Now it's okay, let's send you to the pediatric neurologist or to the pediatric nephrologist or whatever ologist you want to use. Um, and I guess the main question here is at what point would you advise, I guess, any parent who's going through this chain of diagnostic, not getting any answers, at what point would you advise a parent to suggest or push for genetic testing? Because I don't know how much that's on the radar for most parents.
Yeah, I mean, I think, anytime that you notice that there are either like your child is not meeting any certain milestones or like presenting with anything that's abnormal, or if you have any type of neurodiverse diagnosis, what they're finding is there's actually a lot of undiagnosed genetic conditions. And so I think whole exome sequencing is a much faster route to really get to exactly what it is, and from an efficient way. One thing I also wanted to mention is the our foundation has partnered with Probably Genetic to also increase access to genetic community testing within our own community. And it's a no-cost genetic testing program for pediatric epilepsy disorders. It's patient initiated, so it includes genetic counseling to explain any of the questions or findings. So probably genetic is another route that people can go. But I think as it relates to, it's challenging when you have also these subdiagnoses because often a lot of our doctors have never met any patient who has our condition. And so you're really left to, see what, like if they can find out what's happening. And so I think joining any of these social networks is also another way to reach out to other parents. And we tell them, like, we've published guides on our site for providers. And part of that is sort of like trust your patients, because we are the experts. Like, we may not have PhDs or MDs, but we are the experts in our child. We know our child better than anyone else. And to be confident and strong, find your voice and advocate for your child, that's one of the best things that you can do.
Yeah. It's it's just it's got to be daunting, and especially families that have other children. So Alex has siblings as well. So just to manage that must be incredibly just exhausting to go through all of that.
It's a lot. I mean, I joke that we live in the bureaucracy oceans. There is always so many different papers and forms and communications among all different hospitals and providers. And, things are fragmented and you can sign so many HIPAA forms, but you really have to be the glue to make all of this come together for your child, right? And then, like you said, there's a ripple effect to the siblings. And, especially when you're in an environment where it could be like this constant fight or flight of what's going to be the next surprise diagnosis that we're going to have, that we're going to
Next symptom
have.
that pops up. Yeah.
Right. What do you do next? And so that's challenging. I mean, I think it's an area that is not, unfortunately, so much of focus is of families. Like I think that the siblings need extra support and attention, and they're often very empathetic and kind because of the environment they're in, and they're, put in a situation sometimes where they need to be more independent than their peers. It's a very different lived experience. And for the caregivers, I wonder too, in terms of you have like lack of sleep and exercise and this chronic persistent stress. Like, does this also create inflammation and potentially disease for your own family, right?
Right, right. Plus,
Um,
from a financial standpoint, if you're not able, one parent isn't able to work, or what if there's only one parent in the equation?
Absolutely. Yes. I've met a lot of single mothers or people who often, like many, I mean, I'm one of the people I know who, like, it is really hard to keep working, to have an employer that it gives you that level of flexibility where you need to drop everything and go to the hospital, or you're trying to manage all these different appointments. And so you need to flex all your hours. Often, many parents do take on the care for their child, plus all the administrative stuff. I mean, even like home care has been incredibly challenging. We currently have like 4 agencies and 6 nurses. Just and the process, I know there's so much focus on elder care, but pediatrics is really hard. I know a lot of families that, especially if you live in rural areas or certain states in the country, you cannot get support, and your child, like Alex, we have to feed him and bathe him and toilet him and like literally do everything for him. It's like an infant care. So, and from a safety perspective, they're putting everything in their mouth and chewing things all the time or hurting themselves. And so it's a constant monitoring, even just for safety, right? In addition to daily support. So it's a lot for families, and it's very tiring. And so, I so much appreciate even having the opportunity to talk with you, because I feel like our voice is not always heard because people are drowning in their everyday.
Yeah. Yeah. And our conversation is not unlike some of the conversations that I've had with parents who've been on the show. In fact, my very first episode was with a dad whose son had a very rare genetic mutation that that turned into this idiopathic bone marrow disorder, and he was having nosebleeds, and he also had developmental challenges as well, and just this potpourri of stuff that they were all dealing with as a family. Luckily, smart geneticists found this very rare mutation, and the little guy had a bone marrow transplant just last year and is doing so well. And then I had another mom who was on, whose son had is it the MTHFR mutation? It's another methylation mutation, because you had mentioned that earlier. Same thing. She went through dozens of doctors and had the wherewithal to keep pushing and doing her own research. And her son now is a straight A student and a star athlete. And she started a business outside of all of that, or because of all of that. So it's amazing what parents go through, and nothing stops a parent from pushing for the answers.
Absolutely. That we move mountains.
Indeed, indeed. So Laura, just curious though, what physician or what kind of specialist we talk about who's the quarterback of care. So who is that point doctor who's running point for Alex right now?
So I feel like our geneticist is one of 2 experts in the world on Bohring-Opitz. And so I feel like, as it relates to kind of understanding what we should be doing next and what the priorities are, he's definitely the person that I go to. I feel like from the ongoing management standpoint, our complex care service person in Boston and our palliative care provider in Maine have just been like an awesome pair in managing all of our local providers and of all of our Boston providers, of like, all of the different surgeries Alex has, all the different pain challenges he has, all the complex care management of the ongoing symptoms. Um,
And Laura, what are the specialties of those physicians? And if you're willing to name them, that would be great. Talk
my
about
gosh.
these amazing physicians. What specialties?
Oh, their name.
Right.
Yeah. So Dr. Juliana Mariani at Boston Children's Hospital is phenomenal. She should win every single award. She's just one of the best. Because I feel like, often PTPs or pediatricians don't have the capacity or time, knowledge, experience for complex care. So having a complex care pediatrician is so important. Not just, and I would also say even for like when we've had planned inpatient stays, so for example, Alex went for like an orthopedic surgery, but there's all these other elements to an inpatient stay, whether it's like the equipment, childcare life, behavioral health, like physical therapy, all the different other specialties and other medical symptoms that you deal with while you're in the hospital outside of the surgery itself, right? So I feel like she's amazing. And then Dr.
She's a geneticist. She's a geneticist.
The complex care doctor. So
Complex care doctor. Okay. What about, how would you define that? A complex care doctor?
So complex care are like in the nature of Children's Hospital is a pediatrician who works with all the different medical specialists. So all the ologies like pulmonology, gastroenterology, urology, orthopedics, like all the different people, right? You want one person who's going to reconcile all the different information that you're getting, who are like all the different providers want their surgery first or whatever it is, right? Like they are the chief person to help manage all of that. And also, like we see her in an outpatient, but she also coordinates. There's an inpatient complex care team. So when Alex is in the hospital, he's also on the complex care inpatient service, even though he goes there for like ortho surgery or urology surgery or whatever. They manage holistically his needs, right? Not just the specialist.
Wow. And the other physician, Laura, with
So
palliative.
palliative care, Dr. Allison Caldwell at Maine Health is phenomenal. We are so fortunate. They have a 24/7 team. So if Alex is in pain or we're having an issue, we can contact them at any point in time. And that really helps to prevent us from going outside the hospital, like getting admitted to a hospital. Um, and, many people think about palliative care as end of life, and that's not true. They do a lot of things with the quality of your life, with chronic pain, with more complex care. And so that also has been incredibly helpful for us in many different aspects.
Yeah, that's amazing that's available. And but like you said, families who don't live near academic medical centers and are in rural areas, that has to be a real challenge. And so as we wrap up here, Laura, tell us more about how your foundation is helping those families from that aspect, or anything else you want to tell us.
Absolutely. I mean, so we try to also do various types of virtual events, webinars for families on all different topics, and bring in professional providers and families from our community to share their information and knowledge. And we have a resource library on our website where all of that information is available for families. So like we recently did one last week on respiratory illness and how do you prevent that? Because prevention is really key in this space. It's hard once our children get sick and it takes them a really long time to recover. So we also have now recently onboarded a family engagement coordinator who is sort of like a central point of contact for all the families and helping them connect to resources. And then we have conferences every other year for the families to come together and learn from each other, learn about the latest, what's happening in research and clinical management. So those are some of the areas that we support them.
Gosh, Laura, like I said, there's nothing like a mother's love, and you are the epitome of that in all that you're doing. How can folks contact you or the foundation or learn more about it?
Absolutely. So anyone can email me anytime. It's Laura, Laura, at arrefoundation.org. And you can also visit our website, www.arrefoundation.org. We're on many of the social channels as well. You can connect with us on Facebook and Twitter, etc. So look forward to connecting.
Fantastic, Laura. Well, thank you so much for educating us on this uber rare condition and this genetic mutation. And it's my hope that our conversation gets out there and can help other families, and just so they know that there's a resource out there that's thinking about them and paying attention to them as much as you are. So thank you so much, Laura, for being here and just showing your love and passion for all of these families. I so appreciate it. We will put all of Laura's information in the show notes as well. So thank you, everyone, for listening in. I'm Laura Nozicka. Stay well and keep pushing for answers.
Oh my goodness, that's a wrap on another compelling story. Thanks for listening to the Desperate for a Diagnosis podcast. If you would like more information about today's guests or to find out more about Laura, go to desperateforadiagnosis.com. If you enjoyed the show, please subscribe, rate, and review the podcast on Apple Podcasts, Spotify, YouTube, or wherever you get your podcasts. You can also follow show updates and healthcare news on the podcast's Facebook page. If you would like to be a guest on the show, or if you have any questions, advice, or suggestions for our guests, please email me at lauramarie@desperateforadiagnosis.com. Please note, I am not a medical professional, nor am I affiliated with any healthcare, pharmaceutical, or device company. I am an entrepreneur and an independent market researcher focused on helping healthcare organizations better understand the patient perspective. The podcast is not meant to offer medical advice, but to merely share the stories and perspectives of podcast guests. Oh my goodness, that's a wrap on another compelling story. Thanks for listening to the Desperate for a Diagnosis podcast. If you would like more information about today's guests or to find out more about Laura, go to desperateforadiagnosis.com. If you enjoyed the show, please subscribe, rate, and review the podcast on Apple Podcasts, Spotify, YouTube, or wherever you get your podcasts. You can also follow show updates and healthcare news on the podcast's Facebook page. If you would like to be a guest on the show, or if you have any questions, advice, or suggestions for our guests, please email me at lauramarie@desperateforadiagnosis.com. Please note, I am not a medical professional, nor am I affiliated with any healthcare, pharmaceutical, or device company. I am an entrepreneur and an independent market researcher focused on helping healthcare organizations better understand the patient perspective. The podcast is not meant to offer medical advice, but to merely share the stories and perspectives of podcast guests.